So this first part is just to show the concept of acute stroke. So we might treat a lot of diseases, but nothing's more important than the acute stroke patient. And the idea is that the race is won with the team. It's not the driver, it's not the engine, right? It's like every role is important. So if anybody tries to minimize that or tries to suggest otherwise, that's not true. You're only as good as your entire team in this kind of scenario. So this is from a couple years ago, right? I don't know if anybody follows Formula One. Ferrari's not very good anymore, but back in the day, Ferrari set the gold standard. It's because their pit crew is pretty efficient, and so this is just a concept that we work as a team, and the success as a team, it's a team sport. It's not really individual sport. So interventional neuroradiology is just based on IR principles. All it is just taking IR principles and working in the brain. The only caveat is we just have a couple of ways that we can cause more complications, so we put a lot more emphasis on that. So today's talk is mainly about neurovascular work, not really biopsies or procedures. But so one of the biggest things in interventional radiology is if you spend a lot of time, or just IR, and you're trying to get to somewhere, and you get a wire exactly where you want in the splenic artery, or you get it in the brain, the biggest thing is you don't want to lose access. So when you're on the table working with somebody, think about how that could happen. That could be like a tubing snagging on a wire. That could be like the coiling catheter when you pull the little hub off, catching on something. So just be mindful of something like that. And we've all done it, right? I've done that. So just remember, when you get to a certain place in IR, in terms of access or groin access, you don't want to lose access. So if you get a wire in a really tough femoral artery, you don't want to give that up. You go get a dilator, go get like another catheter, you can exchange. But once you have access, you don't want to lose it because you don't know when you're going to get back in. The other concept is you can never have enough support when you're doing brain work. So you're pushing catheters from the femoral artery to the brain, and you're trying to get 1 millimeter responses. Whenever we push the microcatheter, we look at the screen and we're saying, okay, whatever incremental push I gave, I want to see it on the screen. But oftentimes, if you don't have enough support, it lags behind. So if it lags, you're really not really working in real time. You're pushing something and you're waiting for a response. You want to operate in real time, one-to-one feel. And so if you see a patient and they look, you happen to know that they have atherosclerosis, coronary artery disease, you know that the rest of their vessels are going to be pretty crunchy too, right? So stroke, atherosclerosis, these don't spare your heart blood vessels, they don't spare your aorta, right? It's everywhere. So when you have atherosclerosis, it involves all the blood vessels. So in that circumstance, you want to think about pulling a bigger guide catheter, right? Oh, do you want like a 45 centimeter sheath? So just, again, it doesn't really matter what the actual sheath is, it's just the concept. Oh, hey, I think this person's morbidly obese. Do you want to consider radial access? Do you want to consider, like Tony and I had a similar case. He's like, I think this is a better radial access case. And I looked at it, he's like, I was like, you're totally right. And so we set up for a radial access and the stroke went well. But it's just these kind of things you think about. If you go from the groin, sometimes you can just never have enough support. I know, I'm thinking from a week ago, they had a complex case in a young patient, right? Or a stroke. You don't want to be battling the neck or the aorta. You want to treat the brain, right? So start with success to begin with. Sue, do you have a question, or are you thinking something? Okay, sorry, I thought you had a question. Okay. And the other thing is bubbles. The problem with bubbles is that they can, sometimes they go away in the brain, like very small bubbles. They don't really cause significant strokes, but the big bubbles do. So just be mindful, just use your good technique to avoid, getting bubbles and things. In terms of when you pull wires out quickly, you create a vacuum. So the same reason when you pop your knuckles, that it makes that noise is because you can generate gas in there. You can generate gas in anything if you pull equipment out quick enough. So if you have a guide catheter in place, you have this slug catheter and you whip out the slug catheter, you're going to create a vacuum, and when you create a vacuum, you're going to create nitrous oxide or whatever, right? It's going to cause air bubbles. So just go slow and just use good technique. So these are the main blood vessels that we're going to be going into. This is just an archiogram, right? Just depicting the anatomy. And so it's not important to know all the detail. It's just important to get a good sense, okay, we're on the right, we're on the left, and we're in the front or the back. So the main take-home point is that there are two vessels in the front of the brain, the carotid arteries, and there's two in the back, the vertebral arteries. The ones in the back join to make the basilar artery. The ones in the front go into become the MCA, the ACA. So, and I'm just showing a diagram of a hockey stick catheter. So this is why the hockey stick catheter was invented, because it kind of just hooks naturally into these vessels, right? Okay. This is the ideal placement of a catheter. You want basically the tip of the catheter to kind of face the inside. So if you're doing an angiogram with somebody and their catheter is kind of facing the back wall, you kind of want to say, oh, okay, are you happy? Again, everybody kind of responds to feedback differently, but the idea is that you're just asking questions for the patient's safety. So you just say, oh, are you kind of happy with that position? Or like, let's say it's kind of low and it's a common injection. You want to kind of get in a good position where everybody's, it's not going to cause a complication. So if you have a catheter, like instead of this facing the middle and you have it facing the sidewall, what's going to happen is you can do a routine injection, it's not a big deal, but if you do a 3D, you can cause a dissection or something like that, right? So that's what you're trying to avoid. Okay. So this is a frontal angiogram, right, of the right internal carotid. So the MCA branches on the side, ACA branches in the middle. So it's pretty easy to identify in the frontal view, right? Everybody can look at the frontal view and say the ones that go to the side are the MCA, ones that go to the middle are the ACA. Important thing to remember, whenever we do a stroke, clots stop at bifurcation points. So the clot is always going to stop at this, where this wide, this kind of bifurcation. It may stick into one branch or the other, but basically this is where they stop. The lateral is a little bit more tricky. Just remember, the MCA branches are lower, the ACA branches are higher. So why is this important? Because when we're all doing an angiogram for a stroke patient, let's say you open up the MCA, sometimes the clot can break off, and sometimes there could be an ACA occlusion too. It's not, we have missed this, everyone's missed it. So you don't realize sometimes there's a clot up there too. So when you're looking at this, just make sure you see all the branches. And if you don't, it's important to ask questions. This is the left, same concept. MCA on the side, AC in the middle, same thing. MCA branches are lower, ACA branches are higher. This is right vert origin. That's kind of how you want your catheter position. So one important fact, the most dissected artery in all of angio and neuroangio is the right vert. It's not natural to put a catheter in it from the heart, from the groin. It's much easier to get a catheter in from the radial artery, but when you're going from the femoral artery, you're going into the innominate, into the subclavian, and going back into the vert, and sometimes it's just that kind of stress can dissect the vessel. So it's the most common. So oftentimes, if you don't need to do a right vert, you just skip it. So you guys, if somebody's struggling with it, like, oh, were we able to get the information from the left vert? Because sometimes if you're in the left vert and you just slam the injector with a hand injection, or you just have a higher injection rate, you can probably reflux it in the left vert. You don't even need to do the right. So just some good kind of gamesmanship, right? Same thing, left vert. So left vert's much more natural for the catheter to kind of sit like that. This is the vert. Okay. So it's important to kind of understand the lingo that people use. Again, a lot of you guys know this, but it's just important that we can just kind of go over the concepts one more time. Your groin sheath is your thing that's going to stay in there for the whole case. Your balloon guide catheter is your part of your initial access, and through that you always need a select catheter. It could be hockey stick shape, or it could be reverse curve shape. So the reverse curve shapes are like the VTK or the Simmons. So the hockey stick shaped catheter is always better for the right side. The reverse curve is always better for the left. And then through that, we have our aspiration catheter or intermediate catheter and the microcatheter and the microwire basically chaperone them to the top. We always want to get the clot out in one piece, first pass, that's the goal. And remember, stroke catheters are much longer than our diagnostic, or let's say you're doing an aneurysm case. So when in doubt, just grab the longer one, right? So if you're looking on the shelf and you see 125 and 131, just be like, I have the longer one available. Just, you rarely will regret going with a longer catheter. Just some weird facts. Okay, so if you have a catheter, it's based on the outer diameter. So if you have a 5 French catheter, that means 5 French on the outside. Whereas you have a 5 French sheath, that means it accepts a 5 French catheter. So just kind of strange concepts. We talked about that. If you could remember one thing about catheters and sheaths, just remember a 6 French guide sheath is the same thing as an 8 French catheter. So like a Neuron Max is the same thing as the balloon guide catheter we use, the Walrus. Walrus is a 8 French balloon guide catheter, and Neuron Max is 6 French guide sheath. Just kind of weird nomenclature, but just remember that. They're all.
Quick question.
Yeah.
I noticed that the 6 French Sophias, those are 070 catheters. But we have Zoom 71, and we have Jet 7. So just remember that the Sophias, those 6 French, are actually 070 catheters. So just a quick number, you're saying 6 that correlates with the outer diameter, but for some reason that 6 French Sophia stays 6 French as 070.
Exactly. So how did these come up with like 5 French, 4 French, 6 French? So when they first started in this stuff, they came up with these like little 3 French catheters for kids. Then they realized, oh, we can make them a little bit bigger, so they made them 4 French. Then they realized, oh, we should start using 5 French for diagnostics. So 5 French catheters are pretty much standard for diagnostics nowadays, the way people typically do. And then they started doing stroke treatment. Then they realized, oh, we can suck up the clot with a 6 French catheter. And as you know, we're trying to get bigger now. We have the 088, which is like basically an 8 French catheter, right? So it's just every year things are changing and advancing. So the sheath is based on it gives you color. It's kind of useful. So you'll see a lot of stuff. The main colors that we deal with are, this didn't come out very well, but 6 is supposed to be green, and blue, 8 is blue. So you're just going to be seeing a lot of blue and a lot of 8 sheaths. We kind of talked about this. Sometimes you want to use a longer sheath, gives you more stability. And the reason it gives you more stability is if you make a puncture in the femoral artery and it's like really loopy, what the long sheath does is it just straightens it out. It creates like a short distance between 2 points, right? It doesn't take the turns as well, but it just keeps it straight. Again, so if anesthesia wants the A line, you kind of have to upsize one size. There's a company that makes a half-size French sheath, which is we're looking into. Like, so for example, in stroke we use a 8 French groin sheath, but they make an 8.5 for like if you want to do the A line. So we're looking into that, but that's just kind of a something we're not sure about. All right, so this is kind of stuff we already talked about. But so, what's the major take-home point? So if you're doing a stroke and you have a guide catheter, let's say a ballast or a Walrus, to get that in place, you have to take it up over a long select catheter. So that has to be at least 125 or 130 centimeters. That's either going to be your hockey stick or a BTK. 100 centimeter won't work because it barely will be sticking out the nose. So these are the kind of different shapes, right? So this is your standard hockey stick catheter, this is your BTK, and this is the kind of the Simmons. We talked about this. And this is just showing kind of how you use reverse catheters to access certain blood vessels. One way you can help your operator, depending on who you're working with, and they use a reverse curve catheter, they don't use them too much. Anytime you pull out a reverse curve catheter, you always just hand them a Benson wire. Because remember, if you pull on a Simmons or a BTK, where does it naturally go? It goes forward, right? So if you pull on a hockey stick catheter, it will pull back. It's natural. If you push on a hockey stick catheter, it pushes forward. But these reverse curve catheters, you pull on it, they actually engage forward. So you always want to, if you're going to pull it out, even in the body world, I'm pretty sure most of the time they'll want like a wire to pull out their sawsock here, whatever, All right, we talked about this. We don't use microcatheters as much for stroke because you used to need microcatheters to deliver stent triggers, but mainly now we just try to aspirate the clot out. We like to J the wire because it makes it safe and atraumatic. So I'll just show a couple cases. So this is a left internal carotid artery angiogram. I'm not sure how well it's projecting, but normally the biggest trick in angio is you're looking at stuff and it's hard to know what you're missing, but if you look closely, there's definitely a filling defect, kind of like a Y-shaped filling defect in this vessel. this is before we used a centrifuge, and then we had a little distal clot, so we got the clot more distally. And now you can see the before and after. You can see that the vessel looks a lot more clear. So some of the things you're looking for, you're not gonna. Sometimes you don't see a cutoff. You might just see, incomplete filling of a blood vessel. This is another example. So it's kind of a variant. On the right side, there's a little blood vessel that's cut off. You can kind of see a little bit of contrast hanging up there. Hard to see, but you see on this lateral view a little bit of contrast hanging up there, right? So the AC branches up here and the MCA ones are lower, so we know we're looking lower. Okay, we get a wire out there. We do a run. Okay, we put a centrifuge. And now look at before and after. You can see this little branch. There's kind of just a branch that came off there. All right, it's a little bit. Again, same thing, another kind of incomplete filling defect, but I'm gonna go to something more interesting. So basically that's where their clot was right there. That's another big clot. Anyway, you guys know this stuff. So that's a hockey stick catheter, and that's the balloon guide catheter. So why am I showing this? The balloon guide catheter, or any guide catheter, has no shape. It's just straight. So to get that in place, you have to have some slot catheter. So we get it right there. That's an example of a J-shaped wire. See the wire has like a nice J configuration. Hard to see, but it's got like that hairpin turn. And that's easy. That's much safer to push. Then you can do your run and put your centrifuge out. So these are kind of some of my personal safety things. So the biggest philosophy in our cases has to be staff and team safety, and then along with patient care. But you need to prioritize your safety, because if you're not there, we can't take care of the patient, right? So if anybody gets sick or somebody gets kind of a work-related problem, it's not a safe work environment. So how do we kind of improve everyone's safety? So number one, I didn't write this, but communication, right? Closed loop communication is really useful. Like when you say, hey, let's go do this, and then just, we do this often, we'll repeat it back, and so that way we kind of know we're all on the same page. One of the kind of things that I always try to have safety about, it's not so much here, at other places where I've worked, they'll often pour lidocaine in a cup or something like that, and that's fine, we can do that, but as long as everyone's kind of on board and knows that what we're doing, and you get rid of stuff. The thing with sharps is that everybody should be on the same page where sharps are on the field. You can't have sharps on the table. You can't have sharps. You can't have them scattered around with everybody being aware of them. So one of the philosophies that I find to be useful for sharps is have them in the top right corner, so everybody can safely scrub somebody out, go to lunch, and come back, and they kind of know where stuff is rather than be concerned what they can or can't touch. And also the other thing is, if you don't need a sharp, just get rid of it, because it's really not beneficial to you at that point. Like once you use a scalpel, you're not going to use it for the rest of the case. And if you need one, you can always open it up, but it's only a risk to you and to get injured. And sometimes when things go south, you need to be able to quickly treat patients with kind of bailout stuff. And so a lot of times, a few times we've had to use glue in these emergency situations. And so it's kind of like you just got to be prepared to kind of go through the fire drill. Okay. And then, always, anytime you x-ray, I always ask, does everybody have lead? And if you just take one step to your right, you're always further away from the tube. You're decreasing your dose to yourself. If you're 6 feet away, as you know, it's not a big deal. All right, so that's just the basic one. Does anybody have any questions about that? I'm going to show another quick one. You guys have any questions just kind of about that kind of stuff? All right, so we're talking about intracranial athero. So, majority, 80% of stroke that we see is a clot that travels from the heart or the blood vessels to the neck. 10 to 20% of the time, it's like a plaque that ruptured the brain. So if it's a plaque that ruptured, it's kind of a bigger problem, and it's kind of less easy to deal with because you can't just pull it out. You have to give some medicines or leave the stent. So this is called intracranial atheromatous disease. It's the same thing that happens in a heart attack. The blood vessel has plaque in it, it ruptures, and you either have to put a stent there or give some medicine to clear that clot up. We see it more common in the Asian population because of genetic predisposition. In America, we see it more in minorities, and it predominantly is related to patients who have atherosclerotic risk factors, high blood pressure, hypertension, diabetes. So basically, what do those things do to your blood vessels? So the blood contacts the inner lining of the blood vessel called the intima, and there's 4 things that injure it. There's only really 4 things. You can consider drugs as the 5th thing, but we don't really. You look at normal people risk factors. High blood pressure. When you have high blood pressure, that injures the lining. The other is high sugar. It's not about your blood sugar being 500. Even just elevation of blood sugar a little bit, pre-diabetes, causes your intima to get injured. You get plaque stuck in it. Then what happens? The other thing is smoking. Cigarette smoking really injures the lining of blood vessels. And the last problem is cholesterol. So if you have an abnormal cholesterol profile, you get an injury to that lining, plaque kind of sneaks in. And it happens everywhere in your body. But if it happens in your splenic artery, you lose your spleen, you might have an abdominal pain, but you're not going to die, or you're not going to have a stroke. But the problem is once it happens to the brain, that's when you start getting strokes. So basically what happens is there's 3 ways that a stroke presents when you have intracranial athero. Either the plaque ruptures and you come in and the patient, you don't know if it's an occlusion because of a clot that traveled there or it's a blood vessel that's blocked off. That's when you kind of have to start thinking a little bit more outside the box. Sometimes you get a plaque that ruptures and it sends a little emboli to the rest of the brain, so you get a bunch of little strokes. Or sometimes you need to get more blood to different parts of the brain and you get it's called watershed ischemia. So basically it's flow limited. First line treatment for this is just medical treatment. But let's just talk about how it presents in the hospital. Okay, so this is kind of the treatment. These are not as important. Let me just show a couple cases. I'll just show this one case actually for it's the most interesting one. Sorry, where'd my message go? You have to open my. Oh, I can close this thing.
Yeah, sir.
Where am I looking?
Bottom of the left, there you go.
So this is kind of stroke we never used to be able to treat before, actually. We used to, if somebody had a blood vessel blockage due to a plaque there, we could sometimes think about stenting it, but it was always tricky. So now we know a lot more about it. So now we know that we can open it up and we can do a few little tricks to kind of keep it open. So let me show you this one. It's the most interesting case of all of them. We should write this down. 502. Okay. 502 37085.
Okay.
Okay, go for it.
502-37085.
So these are the rapid alerts that you get, and sometimes they're not that reliable, but do you remember we talked about the ACA being in the middle and being high up? So this is an ACA territory at risk, right? This is that green stuff. Green means go, there's no purple, nothing to do, right? So, I mean, something to do. There's not a big stroke already, okay? Then we take this patient to angio. patient's stroke scale was very high. She had she was aphasic and couldn't move her right side. And you can get that with ACA stroke sometimes, right? It's possible. All right, so let's go. All right, so this is a VTK catheter, right? Not sure what's going on here. And you can see how it engages a blood vessel. So we do a roadmap, right? So let me see what I'm on. Okay, so, all right, so then I get the wire up, right? So it straightens out the vessel, and that's a balloon guide to the mid. All right, so we do a run. Okay, so the ACA is in the middle, MCA is on the side. But let's look. You can see the ACA is included. So where's my second look? You see how this one vessel's open, but the other ACA looks blocked? You see that cut off? Everyone appreciate that? Does everyone appreciate the blood vessels don't look smooth? That means this patient has atherosclerosis. So that kind of cued us in right away. Okay, this patient doesn't have like a clot that went there. And it'd be weird for a clot to go there, right? We always see clots go to the MCA or basilar tip, 90% of the time. So if it goes in other places, you gotta like have your spider sense on, okay, something weird's going on. Okay, but we knew this going in, right? We thought about it. And so what we said is, okay, let's try to aspirate this clot out, try to keep the vessel open, and we'll give some integralin. So this is, I'm just showing I'm getting my wire up, get my wire across very gently, get my wire up, okay? Then I put a Zoom 35 in front of it. And I just hooked it up to the pump. Let's see what happens, right? Okay. So then I do a mag view. And now look, you can see the vessel's open, but it's not normal. Do you agree? That there's clearly some filling defect. It's kind of, it's not completely black. There's some fluffiness there. So that's what plaque and clot looks like. So we know that there's a clot there, but we don't want to keep crossing it, and it's kind of an unusual place to place a stent, because then if you put a stent, you got to commit the patient to blood thinners. So what we did is we watched it, right? It stayed open, watched it for another 5 minutes. Okay, now let's look here. After about 10 minutes, look, it's basically occluded now, right? It's not filling beyond. It's that stump. It's kind of really slow actually, right? So it's open. So we go back up. Okay, so let's see. Same thing. I do the exact same thing. So we get the clot out this time. And this time we were like, okay, let's give some integralin. So we talked to the nurse and we already told them, hey, let's have integralin ready. We're gonna give some integralin. We gave integralin and we watched for another like 10, 15 minutes, and it stays open this time. Let's look at the final, okay? And look, it's not perfect, right? So the vessel doesn't look perfect, but it's still open. So this is where we all are in radiology. We want to make pictures look good, right? So we have to fight the instinct of worrying about what the picture looks like. You just got to treat the patient. So then they got an MRI. So let me show you the MRI. So I'll kind of orient everybody what to look for. This is a sequence called DWI, and basically anywhere that it's white, bright white, that tells you that there's a stroke. So let me just window it so you can see. So we're looking for like big white areas. So you can see that one white dot. Okay, you see that? Maybe another little white dot there. But compared to that whole area that was at risk, we saved it. So the patient's stroke scale went from 25 to 1, right? And she walked out of the hospital. Actually, this is a small stroke right up here, actually, this front. So we didn't, we can save everything. But this just gives you an example how you can think outside the box. So usually we're just going up there, putting aspiration catheters, putting centrivers, but 10 to 20% of the patients have this kind of. So if you see somebody who's ethnic and who has their history says diabetes, hypertension, smoking, or if you see, elderly Asian patient, you kind of have to start thinking about this kind of stuff. And that's where as a team, we have to kind of start thinking, okay, the reason this patient had a good outcome is because we got the clot out, we had a plan, we had the medicine available, right? We could give it. We transitioned the patient for Linta, and so they had a good recovery. So that's just intracranial athero in a nutshell. That's like not what we see that much, but it's just something we should all be aware of.